First planner assisted levitation technique in complicated phaco with opaque cornea. This 75-year-old one-eyed lady has opaque cornea in the sound eye with dense cataract, advised for keratoplasty and phacoemulsification, but the patient refused keratoplasty. Staining of the anterior capsule is a must with trypan blue. Injecting viscoelastic inside the anterior chamber and over the cornea to help visualizing the anterior capsule. Starting capsulorhexis after staining of the anterior capsule using the microincision capsulorhexis forceps. Starting to see the anterior capsule and to see the red reflex behind. Be very careful, meticulous, and slowly in doing the anterior capsulorhexis. And here there's a mild migration of the anterior capsule toward the zonules. So change the direction of the pull toward the center to redirect the capsule and complete it. Hydrodissection with saline and then visco in the anterior chamber to protect the cornea and to do viscodissection. Starting phacoemulsification, starting with the stop and shop technique, and after finishing the lower half, there is rent happen or in the posterior capsule. It's a large big rent and without vitreous coming. So don't take your phaco out in this situation. Keep the phaco probe inside the eye, inject viscoelastic, see where is the other half of the nucleus that you didn't remove. The other half of the nucleus is in the superior part from 10 to 2 o'clock superiorly. Don't get your phaco probe out with an insulin needle like during injecting anti-VEGF. The same part from the pars plana, inject the insulin needle and elevate the part of the nucleus and hold it with the insulin needle. At this time, you can get your phaco probe out, and with the other hand spatula, get it behind the half of the nucleus, and from the side port, another spatula to elevate the nucleus in the anterior chamber. Now you are secure. Inject viscoelastic. Don't leave the half of the nucleus that you delivered in the anterior chamber. Enlarge your incision in order to allow delivery of this half of the nucleus, and using the scoop delivers the nucleus out. Now take 3 sutures of 10-0 nylon to secure the wound, because these patients are all of the time afraid from having vitreous hemorrhage or expulsive hemorrhage. Then injection of intracameral trimethylone to see if there is vitreous in the anterior chamber, doing anterior vitrectomy with maximum cuts up to 2,500 and irrigation from the other side, and getting the whole vitreous and clearing the media, and this helps clarifying the media. Of course, all of the time be in the middle of the pupil in order to keep the rest of the anterior capsule and part of the posterior capsule to allow putting the PMMA IOL in the sulcus. After doing thorough vitrectomy, take your time to remove all the vitreous. Be sure there is no vitreous in the anterior chamber. You can inject viscoelastic, remove one of the sutures to allow the insertion of the intraocular lens behind the iris in the sulcus through the 6 millimeter incision. And after securing the leading haptic behind the iris, you can enter the trailing haptic with the McPherson needle assisted with the spatula to rotate the IOL to keep it in the sulcus with your non-dominant hand. And here is the Sinski hook to rotate and keep the IOL in place, and the dominant hand inserting the trailing haptic behind the iris. After taking the sutures, be sure that the wound is closed and elevate the pressure by hydration of the wound, and secure the iris to be sure that the haptic of the IOL is behind the iris. Thank you so much.